Hello guys, welcome back to Clinically Clear. So today we'll be covering a very short topic, that is aphakia. Now phakia means lens in ophthalmology and A usually means absence. So the absence of lens from its normal pupillary position. The normal position of lens is known as pupillary position, and that position, if the lens is absent from that position, it is known as aphakia. Now there can be many causes. Let's look at the etiology. Congenital aphakia. The lens does not even develop. As we know, the lens differentiates from the lens plug cord, but congenitally it does not even happen. Then it will lead to congenital aphakia. Surgical aphakia. This is the most common type of aphakia, where after cataract surgery we remove the lens. Right, during cataract surgery we remove the lens which has become opaque. The opaque lens, we remove it. So then once we remove it, the patient has no lens. So technically it is surgical aphakia. Traumatic extrusion of lens because of any severe trauma like road traffic accidents or any other trauma to the eye. If the lens gets extruded from its position, or if the lens gets posteriorly dislocated into the vitreous humor, the lens gets dislocated backwards into the posterior segment into the vitreous humor, or because of some other reason, the lens matter itself gets absorbed into the circulation. So these are all some etiological causes: congenital aphakia, surgical aphakia, traumatic extrusion of the lens, posterior dislocation of the lens, and absorption of lens matter. Now, first let's look at the signs. Usually we go symptoms and signs. Okay, let's do symptoms and signs. See, think about it. The patient has no lens. So when the patient has no lens, accommodation reflex is absent. And also, the the lens forms a very important converging part of the eye. So when there is no lens, the refractory power of the eye reduces significantly. If normally it is 60 diopter, now it becomes 44 diopters, 45 diopters, because lens itself is absent, right? So this causes a high degree of hypermetropia. So aphakic hypermetropia has high degree hypermetropia because the lens itself is absent. So everything gets focused behind the retina. So that is why you have visual defect. Both far vision also becomes blur and near vision also becomes blur. Accommodation is not there. Along with that, you have high degree hypermetropia. Apart from that, another thing you need to remember is erythropsia and cyanopsia. Erythro means red, cyanopsia usually means blue. So erythropsia, now see, remember our lens normally filters a lot of the blue and red light. The blue and red light that comes, it gets filtered. But now the patient has no lens. So patient sees more of blue and red. This is known as erythropsia and cyanopsia. So these are the main symptoms. Apart from that, you have certain signs. So obviously you have high degree of hypermetropia. So when we do retinoscopy and refractometry, you can see a very high degree hypermetropia. And the fundoscopy also same hypermetropia changes only you can see in the fundus like short silk retina, pseudopapillitis, small optic disc, etc. Then you have iridodonesis. Now what is iridodonesis? Iridodonesis is the tremulousness or shivering of the iris. Now remember, behind the iris you have the lens. So you have the lens and in front of that you have the iris. So the lens from behind posteriorly supports the lens. So now that the lens is absent in aphakia, the iris has no support from behind. So the iris starts shaking. This is known as tremulousness. So this is known as iridodonesis. Then because the lens itself is absent, the vitreous appears like completely dark. So it appears like you're looking into a dark hole. So jet black pupils. Now, as we know, anterior chamber is from the lens till the cornea, but now the lens itself is absent. So the anterior chamber is very, very deep. And when we do Purkinje-Sampson imaging, normally we see 4 images, but in aphakia, we see only about 2 images. So what are the signs? High hypermetropia upon refractometry and retinoscopy. Fundoscopy also you will see hypermetropic changes. Iridodonesis, jet black pupils, Purkinje-Sampson imaging only 2 images and a very deep anterior chamber. Last, coming to the treatment. We're almost done with it. See, surgical treatment, you can do LASIK for the cornea to increase the corneal power, but why will you do that? Lens is absent, so you will put lens. IOL, intraocular lens implantation. Now, there are 2 types of IOL, primary IOL and secondary IOL. Now, during cataract surgery, I'll remove the cataracted lens, right? Then I'll put another IOL, artificial, pseudophakia. So, that is known as primary IOL. So during cataract surgery, for like a brief moment, the patient is technically aphakic, right? You remove the cataract lens, the patient becomes aphakic, then you add the primary IOL. Secondary IOL, if a patient comes to your OPD with aphakia, patient has no lens. To him you do IOL implantation, then it is known as secondary IOL. But whatever it is, this intraocular lens implantation is the treatment of choice. Understood? Now, optical treatment, in the olden days we used to use it, where we use convex lens of very high refractory power, 10 diopters, 14 diopters. It acts like a lens, our own lens from outside. It converges all the light rays. So, how do we do this? See, now there are two things. You can either use aphakic spectacles or you can use aphakic contact lenses. Now, as I told, 10 to 14 diopters, very high power. So, if you're using spectacles, the lenses are very thick. So, look at this diagram. You can see that the lenses are so thick, the cosmetic value reduces, the field of vision reduces. There is something known as prismatic effect. Basically, let's take a very thick lens, an aphakic lens. Then what happens? The bottom part, it acts like a prism because of its very thick cross section. The bottom part, it acts like a prism. It starts splitting the colors. So that causes prismatic dispersion. So you can see prismatic dispersion, prismatic effect. Then there's something known as jack in the box phenomenon or roving ring scotoma that is characteristic of very thick convex lenses. When you use very thick convex lenses, example aphakic glasses, then you can see jack in the box phenomenon or roving ring scotoma. Then obviously very thick lenses, so spherical aberration, there'll be distortion spherically, there'll be chromatic aberrations because of color splitting. And think about it, let's say only one eye has aphakia. Then you're giving spectacles where you have two lenses, right? So in unilateral aphakia, how will spectacles be that useful? Obviously, you'll prefer contact lenses. All of these disadvantages are absent in contact lenses. Contact lenses has better cosmetic value, no reduction in field of vision, no jack-in-the-box phenomenon, no prismatic effect, no chromatic aberration, no spherical aberration, and contact lenses, you can use it unilaterally, only on one eye, the eye which has aphakia. But the main disadvantage of contact lenses is it is very expensive, a lot of work, you have to keep changing the lenses, you have to wash it, etc. So it is tedious and it can cause many corneal problems in the future. So this is about aphakia, very short topic. So we did the etiology, we did the signs, we did the symptoms, and we did the management. That's it. Thank you for watching.